Hello, everyone. Welcome to AFOMP monthly webinar. This time I will first introduce our moderator today. So, moderator is Dr. Bing Yang, is Kimi Yang from Hong Kong Senatorial Hospital. Currently, he's our assistant senior medical physicist at the Hong Kong Senatorial Hospital, specializing in cutting edge of radiotherapy technology such as MRI-guided radiotherapy, proton therapy, and the cyberknife. He got his PhD from the University of Hong Kong, and he had study experience in China, Nanjing University. So currently, he brings decades of experience in adaptive radiotherapy, motion management, and dosimetry. Dr. Yang is a certificated medical physicist by Hong Kong Institution of Physics in Medicine. Also, currently he serves as the secretary of this Hong Kong Institution of Physics in Medicine. He's the committee chair of the ATC chair of AFOMP and the scientific committee member of Pittsburgh AO. So, as honorable assistant professor in Hong Kong University, Dr. Yang dedicates offers efforts in training and academic initiatives. His scholar continues as a widely recognized with publication of high-impact peer-reviewed journals and presentation at international forums. So please, Dr. Yang.
Okay, thank you for the introduction, Dr. Jin. So good afternoon, everyone, and welcome to today's webinar. As introduced, my name is Kimi Yang, and I am honored to serve as the moderator today for this insightful talk by Dr. Sajeev Thomas. So yes, today's speaker is Dr. Sajeev Thomas, and his expertise bridges the cutting-edge technology, clinical precision, and global leadership in medical physics. And please join me in welcoming Dr. Thomas. And Dr. Thomas currently serves as the director and radiation consultant of OnCall Race, located in Dubai. Dr. Thomas holds a PhD in physics with a specialization in radiosurgery and a master's in radiation physics. His journey includes advanced training at world-renowned institutions. Over his illustrious career, he has held pivotal leadership roles, including director, chief operating officer, and chief medical physicist. And we doing today's webinar, we encourage active participation from all audience. And if you have any questions for Dr. Thomas, please use the chat function, and we will have dedicated Q&A session at the end. So without further ado, let's dive into this critical discussion. And Dr. Thomas, the stage is yours.
Thank you, Dr. Kimi. Am I audible?
Yes, we can hear you.
Yes.
Okay. Thank you, Dr. Kimi Bing, for your kind words. Good morning, everyone, and thank you for joining me today. It's an honor to stand before you to discuss a topic that brings cutting-edge technology, medical innovation, and very art of healing: the evolution and critical evaluation of advanced radiosurgery systems. Radiosurgery has revolutionized treatment methodologies across the globe. It's a testament to humanity's relentless pursuit for precision and progress. Today, we will delve into the technologies that underpin these systems, examine the methodologies that make them effective, and shine a spotlight on the indispensable role of medical physicists in advancing patient care. This talk is not just about understanding the mechanics or science behind radiosurgery. It's about appreciating the profound impact it has on lives, the invisible yet powerful collaboration behind its success, and promise it holds for the future of medicine. So together, let's explore how these systems continue to push the boundaries of innovation, offering and healing in ways unimaginable just a few decades ago. So let's begin this journey into the fascinating world of advanced radiosurgery systems. So OncoRace is a Dubai-based premier cancer networking platform, and we are involved with advanced oncology care and networking throughout the globe. I have no disclosures. In today's lecture, we go through three major advanced radiosurgery systems, methodologies, and the integral role of medical physicists in the context of radiosurgery. The scope of analysis includes gamma knife, cyber knife, ZapX, and a few radiosurgery systems, not in detail. The analysis will compare the precision, motion tracking, speed, treatment efficiency, dosimetry, clinical applications, target localization, accuracy of different radiosurgery systems. We will also touch some of the aspects of end-to-end testing in radiosurgery. We will also discuss some of the technological innovations and methodological advancements in radiosurgery, along with the challenges. So let's take a moment to explore the fascinating history of stereotactic radiosurgery. First, back in 1907, Victor Hosley and Robert Clark developed the first stereotactic frame, which was used for animal experiments. Fast forward to 1947, Ernst and Henry created the first stereotactic frame designed for humans. In 1949, Lars Leksell made a breakthrough in Sweden with the arc quadrant stereotactic frame. A few years later, in 1954, Borgi Larsen and Leksell pioneered proton radiosurgery in Uppsala, opening the doors for more revolutionary approach. By 1961, Kjellberg and Kochler further advanced the field by using 165 MeV protons for radiosurgery at Harvard. Then in 1967, Leksell and Larsen introduced gamma knife prototype. That was a significant milestone. And in 1975, the gamma knife evolved to its second model. Innovations didn't stop there. In 1982, Betty and Derensky performed the first radiosurgery using a Linac system. One of the game changers came in 1994 when John Adler invented the cyber knife at Stanford University, bringing precision to a whole new level. Adler continued his contributions to the field by introducing ZapX, featuring gyroscopic radiosurgery in 2014. Now let's talk about the advancements in techniques. Precision improved significantly with goal-based stereotactic localization and mathematical methods based on CT voxel coordinates. These innovations were reported in 1990s. Image guidance systems utilizing both kilovoltage and megavoltage beams along with cone beam CT revolutionized how radiosurgery was performed. Last but not least, multimodality image registration systems sped up the progress, enabling rapid advancements in the field. From early frames to cutting-edge technology, the journey of stereotactic radiosurgery is a testament to human ingenuity and relentless pursuit for innovation. So radiosurgery, as defined by pioneers like Leksell and Larsen, exemplifies precision and non-invasiveness, addressing the challenges in neurological practices. Leksell's definition underscores its ability to target intracranial tissues with remarkable accuracy. It was offering hope in cases where conventional surgery was not possible. Furthermore, Larsen's contribution highlights the controlled use of ionizing radiation energy, ensuring the eradication of target structures while safeguarding surrounding tissues. That was a delicate balance that defines the essence of radiosurgery. The definition provided by the American Association of Neurological Surgeons complements these perspectives by illustrating the methodological approach to its execution, typically within a single session or up to 5, using stereotactic guiding technologies or stereotactic imaging. Collectively, these insights align to portray stereotactic radiosurgery not just as a technological innovation, but as a beacon of progress in enhancing patient outcomes, particularly in case of high-risk patients or inaccessible conditions. As a revolutionary approach, SRS relies on three fundamental principles that enable it to achieve differential targeting with remarkable precision and efficiency. First, the generation of the dose gradient is achieved by spreading the radiation dose over a large surface area. This ensures that surrounding healthy structures experience minimal exposure to safeguard them from unnecessary damage. Second, accurate and precise localization of the target, that is utilizing advanced imaging technologies and meticulous planning. We can pinpoint the exact location of the target area, ensuring the treatment is directed solely where it is needed. Lastly, the delivery of the small fields to high doses is a cornerstone to SRS. This allows us to concentrate the therapeutic impact on target while maintaining the integrity of adjacent structures. But by adhering to these principles and leveraging cutting-edge innovations, SRS has transformed the landscape of radiation therapy, offering hope and healing to patients across various clinical conditions. Here we can see the gamma knife radiosurgery utilizes 192 or 201 precisely collimated beams that converges at specific focal point. Cyber knife radiosurgery employs multiple distributed beams that converge on the targeted tissue without always forming a singular focal point because it is non-isocentrical. SAPEX system features a gyroscopic delivery method for creating dose gradients. And LINACs, in case of linear accelerators, use numerous non-coplanar modulated fields or successive non-coplanar arcs that converge isocentrically at the largest tissue. So, effective radiosurgery relies on more than one ability to focus multiple beams or arcs onto a precise point where in a three-dimensional place. What is essential is ensuring precision and accuracy. This is achieved through advanced 3D imaging techniques. These techniques includes both frame-based and frameless methods, allowing us to visualize the targets and tissues, surrounding tissues clearly. Moreover, they help to establish the spatial relationship within the three-dimensional structure, enhancing the ability to perform accurate and safe treatments. There are many evidences in the literature that frameless systems could achieve comparable accuracy and precision as frame-based radiosurgery. So today, we will be going deeper into these three systems: Lakeshell gamma knife, robotic cyber knife, and gyroscopic SAPEX. These three dedicated systems, we will be going a little deeper. So if you look into the gamma knife radiosurgical history, in 1951, Lakeshell published the most quoted paper on radiosurgery, the stereotactic method and radiosurgery of the brain, where he coined the term radiosurgery without any specific definition. This paper was actually accredited by two departments, one neurosurgery and the second radiation physics. It was headed by Kurt Lydon, who was a physicist. Initial radiosurgery attempts using orthovoltage X-rays were the collaborative work of Kurt Lydon and Lars Lakeshell. However, Lars Lakeshell's collaborations with Borgi Larsen at Gustav Werner Institute eventually initially for the proton therapy, proton-based radiosurgery, and that eventually lead to the development of first gamma knife, which was installed in Sofia Hemmet Hospital in Stockholm. So nowadays, radiosurgery known as a gold standard, which offer non-invasive solution for all the indicated brain disorders using focused radiation to treat abnormalities with the minimum harm to surrounding tissues. And the latest version of the Gamma knife is Spirit. So if you look into the technology of Gamma knife is a specialized tool with a targeted radiation treatment. It has multiple cobalt-60 sources, which are precisely focused to a central point. The new versions of Gamma knife has 192 beams against the former versions with the 201 beams. That allows for effective targeting and making it a precise option for conditions requiring high precision. So the new Gamma knife systems uses sector-based dynamic collimators, whereas in the old systems, they were using fixed collimators. So the sources are grouped into 8 sectors that open and close independently for beam shaping and efficient delivery without manual intervention. And the patient positioning system, the initial systems, it was a traditional frame-based approach, and the most modern systems like Elite, Spirit, Perfection are having the option to do frameless radiosurgery using frameless mark-based systems, including a robotic couch movement and with the submillimetrical accuracy. So there are many developments in this technology, and which integrated with the new software, which can fuse MR and CT. One of the difference between other traditional, not traditional, other radiosurgical platforms and Gamma knife is its planning is based on MR images. So this is a highly precise and non-invasive brain treatment option, which is also referred as a gold standard in radiosurgery. So if you look at the difference between the old systems and new systems, we could find, this is a study which is from the Pittsburgh group that shows there is excellent agreement between the dosimetric parameters of the older versions, that was a Gamma knife 4C generations, the generations of Gamma knife systems up to Gamma knife 4C, and the Perfection, which is a new generation, which is the first in the new generation of Gamma knife systems. So there is good agreement between the dosimetric parameters of both the systems. So it also comes with a stereotactic con-beam CT. The Gamma knife Spirit incorporates an integrated stereotactic con-beam CT that significantly enhances the precision and efficiency for intracranial radiosurgery. It has the option to treat patients with a frame or without a frame. So it has CBCT features that is providing high resolution 3D imaging directly within the treatment unit that enables the accurate stereotactic coordinate determination, real-time patient positioning verification, and patient transfer without any patient transfer, adaptive corrections without any patient transfer. The stereotactic CBCT supports both frame-based and frameless workflows, and that is also another advantage for the patients. So it also has the capability for adaptive planning. Adaptive planning allows real-time updates to the treatment planning systems based on the changes in patient anatomy or positioning that also improve the patient accuracy and accommodating intrafraction variations. It also comes with an HD motion management. The Spirit system also has a high-definition motion management using integrated high-resolution surface tracking. 6D couch, it also has a 6D couch that also allows patient positioning in 5 degrees, 6 degrees. And now let's see what is CyberKnife is about. The CyberKnife system stands out in radiosurgery by incorporating advanced robotic radiosurgery. It is image-guided tracking allows for precise targeting of tumors, even those that move during the treatment. Utilizing non-isocentric beam arrangements ensures high conformity around the tumor, maximizing radiation delivery to the target while sparing healthy tissues. The implementation of 6 MV proton beams combined with non-coplanar delivery techniques further enhances its efficiency for treatments, making it a leading choice in the field of oncology care. So if you look into the history of CyberKnife, Dr. John Adler was undertaking a neurosurgical fellowship in Karolinska Institute in 1985, and where he has seen the development of clinical application of revolutionary gamma knife by Dr. Lars Lakesell and his team. So then Dr. John Adler also had a fortune to be involved in the development of the first linear accelerator-based radiosurgery system and proton radiosurgery systems, given him a unique insight to the developing a new technology without a frame, without a frame, whom he felt as an inconvenience for the patients. So through one of his former patients who happened to be a physicist, Dr. Adler became acquainted with Schonberg Engineering, a former variant Stanford Linear Accelerator Engineering Group, and it was alongside Schonberg Engineering and research grants to Dr. Adler's engineering team, he developed the CyberKnife systems. He started work in 1988, and the first CyberKnife prototype was set up at Stanford University Medical Center in 1994. As per Dr. Adler's words, he said, "Today, I am convinced that Stanford University and the San Francisco area is about the only place in the United States where one could start a company from scratch that utilized therapeutic radiation." That was his words. So, seeing at the CyberKnife generation, we can see the G3, G4, VSI, M6, and M7 represent progression of technological advancements in precision and radiotherapy. Key features of this system include real-time tumor tracking, robotic arm for precise beam delivery, and synchrony, that is for respiratory motion compensation. Treatment advancements from intracranial tumors to stereotactic body radiotherapy for various extracranial sites, CyberKnife offers enhanced accuracy and efficiency. This is the key advantage of the CyberKnife system, which can be used for areas which are outside the cranium. So CyberKnife system introduced with an image guidance and mask immobilization for stereotactic radiosurgery. It uses a reactive motion synchronization that tracks the target and synchronizes the treatment beam position to the patient's new location. So the treatment planning system utilizes normal breath hold CT scans combined with live tracking or accurate planning and minimal tumor information with minimal tumor deformation. And it has multiple tracking modalities: synchrony spine, that is for tracking spine, that is also available in supine and prone, and synchrony fiducial tracking with the respiratory modeling, and synchrony lung tracking specifically for respiratory related target movements. So this is how the room of the CyberKnife looks like. It uses a sophisticated KV X-ray image source, consists of two ceiling mounted X-ray sources, and it has a corresponding in-floor detectors, and this generate beams that intersect orthogonally, and that allowing the precise pinpointing and tracking of targets throughout the treatment. And the treatment are based on the patient positioning table, accurately bringing to the patient to the imaging field of view. And that point is known as image center. And live X-ray images are digitized and compared with the images which are synthesized from the patient's treatment plan, enabling automatic adjustments of the patient positioning before and during treatment as target motion is detected. This is one of the key features of the CyberKnife system where a live tracking is possible. So the robotic arm, the real-time imaging enabled the precision in radiation therapy or radiosurgery delivery that it minimizes exposure to the normal healthy tissues. So the tumor tracking technology, which is known as the synchrony, tracks and adjusts the tumor movement during treatment, especially for lung and liver tumors. So its treatment scope of this system is much broader in various locations, which includes brain, spine, lungs, prostate, liver, and pancreas. So the tracking methods, CyberKnife uses fiducial tracking based method, that is, or X-ray image guidance or skeletal tracking to adjust for patient and tumor movement during treatment. Fiducial based tracking, small metal markers are implanted near the tumor and tracked to adjust for movement, commonly used for tumors in the lungs or liver or in prostate. X-ray image guidance, real-time X-ray images are used to detect or correct for tumor shifts. In lung tumor tracking, it uses X-ray images to target lung tumors without fiducial markers. Respiratory motion tracking synchronizes radiation delivery with the real-time tumor motion using fiducials, LED markers, and algorithms. Skull tracking. Skull tracking is a technique that uses the skull position in 6 degrees of freedom for precise brain tumor treatments without fiducial markers. So collimator changer functionality is another beauty of this system, which allows the user to automatically changes the collimator housing type based on patient treatment plan. So it has a system targeting accuracy, which is less than 1 mm. And the CyberKnife system features comprehensive KV X-ray imaging, robotic system, and advanced motion tracking, and more treatment options. So CyberKnife continuously tracking tumor is one of the most significant peculiarity of this technology. And the end-to-end accuracy of the CyberKnife system reported is less than 0.5 mm. And the treatment versatility is another unique feature of the CyberKnife, and patient comfort. This definitely improves the patient support, as we know. And the third major player in this segment is gyroscopic radiosurgery, which is a new addition to the radiosurgery family. And SAPEX introduces the new possibilities in advanced radiosurgery. It aims to enhance treatment precision, particularly in challenging cases, by comparing its capabilities with established systems such as Gamma Knife and CyberKnife. So this has a unique advantage of self-shielded equipment that eliminates the need of a radiotherapy bunker. And it has been approved for clinical use in 2017 with the first patient treated at Barrow Brain and Spine Center in Phoenix in Arizona. It is now the system is installed in more than a number of centers in US, in across the globe. I would say it's across the globe. It is dedicated to brain and head and neck stereotactic radiosurgery, and it uses an S-band linear accelerator and integrated minimal shielding. So it does not require a radiation bunker. So at the core of the SAPEX system is a compact gyroscopically suspended treatment head mounted on a dual axis rotational frame. And this enables the delivery of non-coplanar beam trajectories without moving the patient couch. This allows highly conformal dose contributions. The gyroscopic mechanism allows treatment beam to pivot in spherical arcs. It has the capability to pivot in spherical arcs around the isocenter with exceptional mechanical accuracy. So it has a S-band LINAC with a 3 MV LINAC linear accelerator, which is optimized for radiosurgery. And it can deliver high dose per fraction, and a robotic patient positioning system, which has a 6 degrees of freedom capability couch and submillimetrical accuracy for corrections, and a real-time imaging platform. It has a MV and KV platform and an integrated infrared and surface-guided tracking system. And the treatment planning system has an inverse planning algorithm. It's known as Axon. And it has also compatibility with most of the imaging modalities. And it has much more safety interlocks, integrated QA workflows as we see with other systems. So the targeting method is image guidance for the targeting lesions during the stereotactic radiosurgery. And it uses an image-to-image X-ray correlation similar to CyberKnife. it is employed for accuracy and dose gradients. And it has a 6D tracking method that is used for treatment planning and structure localization, similar to the technology used in CyberKnife. So if you look into the comparison of this dosimetrical values of the perfection, the gamma knife with this SAPEX system, we could see that the penumbra of the SAPEX system is much smaller compared to the gamma knife systems. So definitely we could see that it has a penumbra. The gamma knife SAPEX system has a penumbra that is leading from 1.8 to 4 millimeter, where the gamma knife has a penumbra from 2.8 mm to 9 mm. 9 mm is for the largest collimator, where the SAPEX has 4 mm for the largest collimator. So this is definitely going to be enhance the treatment plan quality, especially for single isocenter plans or functional targets. This is going to be very crucial. So energy advantage of the SAPEX 3MV is also higher than gamma knife, which is 1.25. That is also improving the kinetic energy transfer to the cranial targets. So this is another recent study on the dosimetry comparison of SAPEX with gamma knife, CyberKnife, radiosurgeries. And here we could see the study compares the dosimetric characteristic of SAPEX with CyberKnife and gamma knife. And as per this study, SAPEX had a lower conformity index compared to CyberKnife and gamma knife, but no significant difference in gradient index and gradient strength index. And the monitoring unit was SAPEX was significantly lower compared to CyberKnife and gamma knife. And all the three treatment devices met clinical requirements, the clinical treatment requirements for single brain mets. And the SAPEX has the advantage of superior plan quality to CyberKnife and gamma knife with a more conformal dose distribution and a better brain tissue protection. This is what the paper claimed. So SAPEX system with continuous improvements have potential to become a new standard. So there is a possibility this can be improved and this can become a new standard. So this is another paper which is comparing the dosimetry of radiosurgery platforms for dosimetric essential tremor, a neurosurgical treatment. So this report also compares the dosimetrical profiles of three major radiosurgical platforms, gamma knife, CyberKnife, and SAPEX. As per this study, gamma knife GRS, that is a gyromagnetic radiosurgery, and gamma knife has the best dosimetrical profiles for WIM lesioning in this essential tremor treatment. So this also shows this technology is improving. So if you look at the technology of both the systems, we could see that here we have the gamma knife frame with the sectors, and here we could see the SAPEX, which also has a comparable SAD and the features of the focal spot size, and the focal spot size is 1 mm and 1.1 mm, where the energy is 1.25, and here there is an energy of 3 MeV. That is a 3 MV. 3 MV is the correct one. So we will also have a look into the TrueBeam. TrueBeam is one of the radiosurgical platform which is commonly used. However, the key advantage of the TrueBeam is it has a higher dose rate. So it can use the FFF beams with the high definition MLCs, and advanced motion management is also possible with the system, where the treatment time could be reduced for that is an advantage for SBRT and SRS. This is one of the advantages with TrueBeam kind of linear accelerator based technologies. I also just wanted to mention that tomotherapy also has the feature to do the radiosurgery, but the limitation is with the primary collimator, and it is good conformity and selectivity for centralized tumors. So if you look at some of the studies, we could identify that if you look at the normal brain tissue sparing, we could see that the glacial gamma knife has got an advantage, definitely has an advantage compared to TrueBeam or CyberKnife. The same we could see in the case of extracranial dose as well. So this is a recent study which is comparing the non-coplanar VMAT, coplanar VMAT, helical tomotherapy, CyberKnife, gamma knife, and SAPEX. Patient and treatment plan information. They have used 12 patients with single brain tumor, 12 treatment plans per technique, and they have used for SRS 21 to 23 gray, and for SRT they have prescribed 30 to 36 gray in multiple groups. And their key findings were SAPEX and gamma knife showed similar conformity index and gradient index. Non-coplanar VMAT and coplanar VMAT had shorter treatment time. So non-coplanar VMAT and coplanar VMAT had shorter time than other techniques in both the groups. SAPEX is relatively superior in conformity index and gradient index for small tumors. Similar to GK, this is also the same with the gamma knife. While the differences with non-coplanar VMAT and cyber knife diminishes as the tumor volume increases. SAPEX, cyber knife, and gamma knife has longer treatment time than treatment techniques, regardless of the volume. So this is another study which was in the Medical Physics journal. So this is another benchmarking study that compared the performance of contemporary stereotactic radiosurgery platforms with the earlier versions. They evaluated gamma knife icon, cyber knife S7, brain lab elements with Electa Versa and variant TrueBeam, variant edge with HyperArc and ZAPEX. And their key findings were CyberKnife and linear accelerators demonstrated higher conformity, while lower energy platforms like Gamma Knife and SAPEX showed steeper dose gradients. So these are all correlated. So let's go for the comparison of these systems more specifically. If you look at the technology of the CyberKnife uses a robotic system and the TrueBeam uses a gantry-based linear accelerator. Here we could see the Gamma Knife is a cobalt-60 based stereotactic radiosurgery and SAPEX is a gyroscopic radiosurgery system. And CyberKnife is primarily used for stereotactic radiosurgery and stereotactic body radiotherapy. And TrueBeam is for general radiation therapy, intensity modulated radiotherapy, volumetric radiotherapy, and for SRS and SRT, where the Gamma Knife and SAPEX are dedicated cranial SRS devices. And the delivery mechanisms in the CyberKnife is a robotic arm-mounted linac with a non-isotropic beam delivery, rotating gantry linac, and the TrueBeam uses a rotating gantry, where the Gamma Knife has a multiple cobalt-60 sources with a helmet or sector-based, dynamic sector. The new versions are having a dynamic sector-based beam shaping. And the gyroscopic, the SAPEX is a gyroscopic design with a linac-based beam delivery. So the beam type in CyberKnife is 6 MV and TrueBeam also 6 MV with a flattening filter free. Here Gamma Knife is cobalt-60 and the SAPEX is 3 MV. And the dose rate is moderate for TrueBeam. It is high, low for Gamma Knife and moderate for SAPEX. If you look into the precision, we could see the CyberKnife system using a tracking system of robotic real-time motion tracking, that is synchrony. TrueBeam now is using a identify with a variant, or it can be coupled with other providers, or Gamma Knife is using a fixed head or frameless mask for patient immobilization. SAPEX is using an integrated high-definition imaging system for real-time target monitoring. So here, another tumor tracking method, it is available for TrueBeam. It is not real-time tracking, but it is available with the new models. Here also, it is available with the new models, and also SAPEX also, it is continuously detects. And 6D correction, yes, the robotic arm compensates for the 6D correction. And TrueBeam, it is compensated. Gamma Knife, yes, and also SAPEX, it has got the 6D correction. And adaptability for moving tumors, it is best suited. The CyberKnife is best suited for moving tumors, but the TrueBeam gated rapid arc radiotherapy technology is account for tumor movement, and the Gamma Knife is primarily designed for only the tumors in the brain, and primarily the SAPEX is also defined for cranial tumors. So speed and treatment efficiency, if you look at we could see the treatment time. It is CyberKnife is slower, 30 to 90 minutes per session average. TrueBeam is faster, 5 to 30 minutes per session. Gamma Knife is again long, 30 to 120 minutes per session, depending on the number of isocenters. SAPEX is moderate. And beam delivery, multiple non-isocentric beams in different angles from the CyberKnife. TrueBeam is VMAT, it is coplanar or non-coplanar arcs. Or the Gamma Knife is multiple cobalt 60 beams. And it is SAPEX is gyroscopic. And the number of fractions, typically 1 to 5 fractions for CyberKnife. And TrueBeam is 1 to 40 fractions. And CyberKnife, Gamma Knife is typically 1 fraction. And SAPEX is typically 1 fraction. So if you look at the dose delivery and precision, the targeting accuracy is sub-millimeter in precision in CyberKnife. And TrueBeam has got high precision. And Gamma Knife also sub-millimeter precision. SAPEX also the same. The collimator system is fixed collimators in CyberKnife or the incise multi-leaf collimator, or it can also use adjustable collimators. And the high definition MLC, they're used by the TrueBeam. And Gamma Knife uses a sector-based collimator. SAPEX uses a tungsten shielded circular collimation system. And the isocentric and non-isocentric CyberKnife is non-isocentric. TrueBeam is also isocentric. Gamma Knife is isocentric, but SAPEX is again non-isocentric delivery system. So if you look at the clinical applications, brain tumors, CyberKnife is highly effective and frameless. TrueBeam is suitable but less precise than Gamma Knife. And Gamma Knife is best suited and gold standard for brain SRS. And SAPEX is highly effective and dedicated and cranial SRS. That may be the future of cranial radiosurgery. Lung, liver, and prostate, pancreas, best suited for CyberKnife. And TrueBeam can treat, but motion comparison is limited. Gamma Knife, not suitable for extracranial tumors, and SAPEX also not specified primarily for the extracranial targets. Head, neck, breast, and pelvic cancers, CyberKnife has limited applications, but still, because it is due to the longer treatment time, but still they improved a lot with the newer versions. And TrueBeam, best suited for IMRT, VMAT, fast fractionations. Gamma Knife and SAPEX, it is not applicable. For spinal tumors, very effective. It is frameless approach with the CyberKnife, where the TrueBeam can treat, but CyberKnife offers better accuracy. And Gamma Knife, limited applications. It is not for the Gamma Knife, and SAPEX is primarily for brain radiosurgery. And large field treatments, it is not applicable with CyberKnife, but best suited for large IMRT 3D conformal radiotherapy. So if you look at the patient comfort and workflow, patient immobilization, frameless, comfortable positioning with the CyberKnife. TrueBeam also frameless, conventional, and immobilization. Multiple options available with the TrueBeam now. Gamma Knife requires invasive stereotactic frame or frameless mask in newer models. SAPEX is frameless, eliminates the use of invasive head frames. So the treatment time is longer sessions. And if you look at the technologies, the methodologies, Gamma Knife uses 100 fixed cobalt 60 sources for isocentric non-coplanar irradiation. CyberKnife uses lightweight, high-energy LINAC with a robotic delivery system. SAPEX uses a 3 MV S-band linear accelerator with a dose rate of 150 mu per minute and a mean energy of 1.15 MeV. And dosimetry characteristics, the performance SAPEX offers comparable or superior dosimetry quality to CyberKnife and Gamma Knife for single brain metastasis. And the dose distribution of SAPEX demonstrate faster dose drop-off compared to CyberKnife and Gamma Knife, resulting in a smaller volume of brain tissue receiving significant dose. And treatment efficiency that exhibits significantly lower monitoring units for SAPEX and shorter treatment times compared to CyberKnife and Gamma Knife. So Gamma Knife beam delivery system originally used the frame-based targeting, and the newer models accommodate the mask-based system. And CyberKnife beam delivery frameless robotic system with non-isocentric and non-coplanar irradiation from robotic arm. And the SAPEX beam delivery is a methodology is gyroscopic system with a mask immobilization and a limited source axis distance of 45 centimeters. And treatment localization, Gamma knife uses stereotactic head frame. Cyberknife and SAPEX utilize beam image guidance and mask immobilization. And SAPEX employs image-to-image X-ray correlation and 6D skull capping. And shielding requirements, Cyberknife requires radiotherapy volt. Gamma knife also require a dedicated shielding, but the SAPEX self-shielding and eliminates the need for a volt. And localization technologies, SAPEX uses X-ray and skull tracking methods. Gamma knife uses mask immobilization and CBCT, and the Cyberknife uses KV X-ray imaging and robotic tracking. Real-time verification, SAPEX potentially uses ME imaging for real-time verification. Motion management, Cyberknife offers advanced motion tracking and frameless treatment options. So coming into the radiosurgery team, the radiosurgery team involves neurosurgeons, medical physicists, and radiation oncologists. Therefore, this treatment modality requires clear definition of roles and responsibilities, and there are multiple guidelines and publications, guidelines, protocols, everything available from different sites. If you look at the pivotal role of medical physicists are basically the designers of the problem. Even we could see that even Lars Lakesell could technically develop a system with the physicists. So the physicists are the designers of the radiosurgery method. Therefore, the physicists also play an important role in the system commissioning, like beam data acquisition, modeling, machine performance validation, establishing quality assurance, verifications using quality devices, and the treatment planning expertise, research, innovation, training, mentorship, etc., etc. So medical physicists are playing an important role in the development, execution, and the operation of the radiosurgery programs around the world. So this is one of the beautiful, beautiful article we could see from the AAPM and RSS group on the responsibilities of the medical physicists. So this, according to this, and as per the other publications, we should understand the equipment acquisition is an important step where the physicist's expertise is crucial. So this program has to be defined and designed by a qualified and experienced physicist. It is not only the system commissioning or performing the acceptance testing, but also designing the program, planning and acquiring the equipments also involves some key responsibilities, and it also play an important role in the quality of the radiosurgery program. So in the system commissioning, that involves performing the acceptance testing and commissioning, including validation of the treatment planning system, accuracy of targeting, image-guided systems, record and verify systems, and implementing and managing a QA program to ensure the continuous proper performance of the treatment delivery and immobilization and simulation devices, image guidance systems, treatment planning systems, and patient-specific QA software devices are done from the very beginning of the program. And also, it is important to establish a comprehensive safety checklist for the entire treatment process. And it also involves incident learning system, facilitate and manage the clinic's participation in the incident learning system to evaluate the deviations in the planning or treatment delivery. And the other important role is on the dosimetric treatment planning, that is perform or supervise the dosimetric treatment planning process, providing appropriate supervision for each task is the role of physicist. Task treatment plan review the final treatment plan for accuracy and deliverability with the radiation oncologist. Treatment plan validation, validate the chosen treatment plan, delivery parameters via an independent dose calculation and potentially a phantom measurement or a dry run. And the treatment session supervision. In most of the countries, there is a regulation to supervise the SRS or SBRT treatment sessions, with the first session requiring a personal supervision by a qualified medical physicist, and the subsequent sessions requiring a direct supervision by a qualified medical physicist or a medical physicist under QMB supervision. So this is mandatory in some of the countries as per the regulations. So the technological innovations, if you look at the technological innovations, imaging advancements includes 4D imaging, Conbeam CT, MR-guided systems, provide real-time tumor tracking and precise positioning for radiosurgery. And the delivery mechanisms, we could see micro-multi-leaf collimators, robotic arms, helical delivery systems. These all systems offer a flexible and precise dose delivery. And software integration help and the AI for adaptive planning, machine learning, and advanced dosimetry systems to enhance the treatment efficiency and accuracy. So if you look at more into the methodological advancements, the treatment planning using the Monte Carlo simulations, which is available in CyberKnife, and also deformable image generation for adaptive therapy, and the verification techniques using EPID, CBCT, radiochromic film, and ion chambers. So quality assurance includes the daily, monthly, annual QA protocols, anthropomorphic fandoms, and accuracy checks. AI-based countering, online adaptations, and workflow integrations are also available with the new advanced features. So this is something I don't want to miss the end-to-end testing, because as I noticed, some of the unexpected organizations or even not serious about the end-to-end testing, because the end-to-end testing is a radiosurgery, evaluate the entire treatment process from the initial imaging to the dose delivery, ensuring all components function correctly together. But in a patient-specific quality assurance, on the other hand, only focuses on verifying the accuracy of the treatment plan and the dose delivery for each individual patient, identifying any discrepancies between the plan and delivered dose. So this is important to have an end-to-end testing which is beyond the patient-specific quality assurance program. The reason is the end-to-end process control will help us to identify the weakest link in the process. If you look at radiosurgery, this is an end-to-end, this is a chain of procedures that start from the localization, treatment planning, treatment positioning, and treatment delivery. So the weakest link in this whole procedure is going to define the accuracy of the whole procedure. So an end-to-end testing in radiosurgery, which is also known as an end-to-end quality assurance, involves verifying the entire treatment process from localization, planning to delivery to ensure accurate dose delivery to the target. This includes evaluating geometrical accuracy, dose distribution, overall functional integrity of the treatment planning system, etc. So this is also important to ensure the precision in radiosurgery. End-to-end testing is very crucial to achieve this goal. And this is an important testing. There should be this during the end-to-end testing. Thorough testing is crucial in radiosurgeries for safety and effectiveness. Example, the testing should covers localization, dose planning, patient positioning, system calibration, and treatment efficiency. Treatment delivery. So it should have a testing goals to ensure that all the processes are in the right place and in the right levels and the right limits. So if you look at the accuracy and precision, this shows the critical aspects of accuracy and precision, especially the localization accuracy, is vital for targeting the tumors precisely, ensuring healthy tissues to receive minimal radiation exposure. So advanced radiation imaging techniques play a key role in enhancing these capabilities, while real-time tracking technologies allow for adjustments during the treatment. So a robust quality assurance protocols are essential to validate the performance of these sophisticated systems without any doubt. So therefore, ensuring quality in radiosurgery, we need to verify each and every component because it involves a high dose, so it demands high awareness. And it demands a prospective process and culture. A learning organization approach is very essential. And what is a physicist? As a physicist who designed the stereotactic radiosurgery, he has the information, he has the resources to understand what is achievable and what is not achievable. And there should be a multidisciplinary risk analysis with and also a valid knowledge sharing and with the experience of the people with the clear definition of the knowledge, clear definition of the roles also are important in ensuring the quality of radiosurgery. So it would also recommend audits from external experts and quality assurance equipment also requires QA in many situations. So the challenges, if you look at the challenges as we are running late time. So if you look at, I'm concluding with this slide. So the challenges in advanced radiosurgery, if you look at the complexities, the calibration of the drift of maintenance of robotic systems or the delivery systems are to be maintained. And accurate modeling of the complex beam geometries are also challenging. So resource allocation is very important. And also it is the upfront cost for the equipment infrastructures and for the staff and training needs to be allocated. So training requirements also play an important role because the training and experience and the education of the key roles, the key people involved play an important significance in assuring the quality of the technique. So the patient accessibility is also an important challenge for the future for reducing the geographic and economic disparities in radiosurgery availability. So if you look at the future perspectives, more integration to AI and also the personalized medicine like biomarker-based treatment stratifications and global accessibility, low-cost systems for scalable features for developing nations and telemedicine integrations and developing energy efficient accelerators and recycling and the reuse of treatment system components. These are all going to be the future challenges. So I would like to conclude that advanced radiosurgery systems definitely revolutionize the cancer care through innovation and precision. So radiosurgery involves high dose and it demands high awareness, and a multi-platform radiosurgery technologies provides more options for patient treatments nowadays, and also a multidisciplinary approach is essential, and the training and educational requirements to be met, and the quality control and end-to-end testing, including the quality control for the quality control devices, are crucial in ensuring the quality. So selection of equipment also depends on the clinical requirement, and there is the essential role of physicists in ensuring the safety, accuracy, and clinical excellence, and the development of this technology to be acknowledged. And it further develops emphasis on the collaboration, research, and training, and drive to future advancements. Thank you.
And thank you, Dr. Thomas, for your comprehensive and thought-provoking presentation. And I saw some questions in the Q&A from one audience. So the first question is, which system supports DSA images like for AVM treatment?
Sorry, which system? Dr. Kimi?
Yes.
Could you repeat the question?
The first question is, the audience asked, which systems support DSA images for AVM?
Gamma knife supports DSA images, and for the AVM treatment, it has an option to view the DSA images in parallel to the, in tandem to the other images, the MRI or CT images.
Okay, thank you. And the second question is, which system has cloud-based solutions?
I think the most of the systems are having the cloud-based solutions, but it's all comes at a package. It all depends on the purchase deal with different institutions based on the requirements. So most of the radiosurgery systems has got these options, the cloud-based.
Okay, I think because in our center we also has 179. I think at the time when we installed the 79, at that time the Accuray didn't provide the cloud solution, but I think now they do have some like online approval system for oncologists. This may also could be considered one of the cloud-based solutions. Yeah.
Yes.
So the third question is that, does any system have inbuilt or automated QA solutions which can speed up SIS processes?
CyberKnife system and the Gamma knife system has got some of the automatic QA solutions. So because in CyberKnife, it has its own end-to-end testing, which is one of the beautiful, the beautiful process we have to do the, end-to-end process, end-to-end testing of the device. Similarly, in Gamma Knife, there are some of the tests like daily QA, daily QA are the provided by the manufacturer. So it is integrated with the system.
Okay. So another question is, what are the scope of advancements in radiosurgery in future, especially regarding the ZapX?
Yes, we have the SAPEX now. It looks like the future of cranial radiosurgery, looking at the technological, the experiences which are shared by different centers. It has few clinical advantages compared to the existing cranial systems. So SAPEX looks like a good, maybe a future technology in radiosurgery.
Yeah.
What do you think, doctor?
Yeah, actually, from my point of view, that the ZX is kind of a competitor to the Gamma Knife, actually. So in my point of view, actually, because regarding the Gamma Knife, so one center has to replace the cobalt source, right, every few years, and it seems that like for ZX, but at first both ZX and Gamma Knife focus on the intracranial lesions, right? So it looks like the scope of their treatment are the same. And although I think in your presentation that some studies show that Gamma Knife presented some like dosimetry advantage, but I think if giving more clinical cases, if in the future there are more treatment outcomes from the ZX, so I personally believe that ZX could achieve similar outcomes as the Gamma Knife. Yeah, that's my point.
Yes, I do think the same, doctor.
Okay.
Because it is already has many of the similarities and much more capabilities.
Yeah. So maybe I have another question for Dr. Thomas. That so do you have about since we are talking about the SIS, so people are curious about the small field dosimetry. So in your center or in your experience, which protocol would you recommend to follow regarding the small field dosimetry? And will you prefer to perform some patient-specific QA for the SIS? If yes, what kind of QA tool will you use? Some like measurement-based QA or independent dose calculation tool?
Yeah, in my previous center where we had a CyberKnife M6 machine, we used to follow the TRS 483, that is for the narrow dosimetry, and IAEA. And we used to do patient-specific QA using a PTW Phantom. And we used to calculate the gamma values before we do the radiosurgery for every patient. So we used to follow it very strictly with the CyberKnife system.
Is that the PDW Phantom specifically for designed for the SIS QA?
Yes, that is a PTW Phantom with 1,000 detectors, 1,000 array. I remember it is 1,000 or 1,200 array. There was two models. So that is SRS arrays we had.
Okay. Oh, then there's another question coming. So what will be the end-to-end testing of Gamma Knife?
Gamma Knife, in my experience, I had to design and develop my own Phantom to do the end-to-end testing. So when I started with the Gamma Knife, there was no such Phantoms available. So I had to design my own Phantom and created to do the end-to-end testing. That is what we could do. Otherwise, Gamma Knife, in the practice in most of the clinics, they focus more into two aspects. One is the testing of the MRI, CT, DSA systems, the imaging part. That testing will be used using some commercial phantoms or design phantoms like Lucy phantoms or modest phantoms or something like that, and estimate the take the measurements. And in the other side, because it was believed that there is not much moving components with the old systems. So it is depends on the institution which has the capability to do the kind of testing. So in my experiences, I have used my own phantoms, which is designed with adaptability to the phantoms for doing the end-to-end testing. And other ways are with Lucy and models and different phantoms are available to do that. But I don't think people are doing a patient-specific QA with a gamma knife. Most of the centers may not be doing it.
Okay, thank you. And maybe last question from me. And since Dr. Thomas, you have commissioned the first of their kind a gamma knife, cyber knife, and tomotherapy program in your region. So may I ask that when you commissioned these systems, are there any like challenges in setting up this system in your regions? For example, some regulation regarding the radioactive source, cobalt 60.
Yes. I understand your question. Yes. Always, there are country-specific regulations for setting up this technology. Even some of the centers where I involved are facing the same problem because in some countries, especially the systems like Gamma Knife is new, it is the first step is to convince the regulatory agencies because we have to convince the regulatory agencies about the systems, its safety, accuracy, so many components. So it takes more time than traditionally we commission a LINAC. And whenever we have the unique systems like cyber knife or gamma knife or tomotherapy like unique systems, it always going to be a case by case because there is nothing to generalize. And so the process will take usually more time in this kind of cases. And gamma knife, it will be much more because the sources are involved.
Okay,
This is my experience in the region. I don't know what about other region.
Yeah, it's always like challenging to because I'm working in Hong Kong. In Hong Kong, we do have there's a center running gamma knife. So that's fine about the regulation part. But the trending that I see is that like it seems that the regulation on the radioactive source should become tighter and tighter. Maybe so. This is also one of the reasons I think ZX does have the benefit over the gum knife. Yes, so personally, I also think that as mentioned in your presentation, the SIS, including SBRT, is very important technique in radiation therapy. And also, I also agree with you that the role of medical physics is also becoming more and more important because SIS, SRBRT are very unique and special techniques. So I think the pivotal role of medical physics that we, for example, the QA and commission system, set up clinical protocols for the treatment to maintain the accuracy of the whole system are very, very important. So yeah, I think if there are no more questions, I think the time is also up. Let's thank Dr. Thomas again for the wonderful talk and the wonderful insights. And thank you for sharing your unparalleled expertise and vision. So if there's another issue, maybe let's call an end of today's webinar. So have a wonderful day, everyone. I think we can see you all in the next monthly webinar.
Yes, thank you, Kimi, and thank you, Dr. Sajeev, for this wonderful session. And I would like to thank all the participants for their patient listening and active participation by asking many questions. It was very insightful. And once again, thank you very much, Dr. Sajeev Thomas, for the comprehensive and comparative analysis. And also at the same time, for emphasizing the pivotal role of medical physics in ensuring all the parameters as well as to ensure the proper radiation delivery to the patient. Thank you all. See you all in the next AFOMP webinar.
Okay, thank you. Bye, everyone.
Bye.
Thank you. Thank you. Bye.
Thank you. Bye.